approach to epilepsy from me, Dan Mercer. Now then, let's begin. So we're going to talk about a couple of things, and there's going to be these icons at the bottom so you can keep track of where we are on the slides. We'll begin with the epidemiology, the etiology of epilepsy, as well as the pathophysiology. We'll go into the classifying of epilepsy, because there's quite a lot of jargon to understand. We'll then talk about the anatomy of a seizure, so what happens when we're actually seizing. We'll look at the differential, what else could epilepsy be? We'll have a quick look at the labs, the investigations, and then management of a patient with epilepsy. So let's grey out the others and begin with epidemiology. So a couple of really quick facts for you is that 1 in 10 people in their lifetime will have a seizure. And in fact, 3% of us all are at risk of epilepsy. And epilepsy is a preponderance to have repeated seizures. Okay. So if we look at the etiology, or what's also known as the causes of epilepsy, well, why do people have seizures? So there are a number of things that are implicated. Of course, genetics is implicated. Some people have particular genetic mutations, for example, to the GABA receptors in particular, but hundreds and hundreds of genetic mutations have been identified linked to different types, particular juvenile onset. Viruses, so think about herpes simplex virus, HIV, these things, chronic viruses that have a preponderance for the nervous system can cause epilepsy. Structural changes, hence a castle. So structural changes that I'm particularly thinking about here are things such as congenital malformations of different regions of the brain. And then metabolic changes, so derangements of your potassium, calcium, sodium, magnesium, phosphate, all of them will cause issues. So the pathophysiology of epilepsy, well, what's going on? Well, we know that we have these electrochemical circuits buzzing around in our brain, and it really is just a case of trying to keep them under control. It's a seesaw effect. Too much firing and things will go out of control, and that's when you have a seizure. There's too much electrical activity in the brain, far too much. And it's a seesaw between the things that make the neurons want to fire electricity and those that want to depress it. Now, the classic neurotransmitters that every med student should know are GABA, red for inhibitory, and glutamate, green for excitatory. Okay? Too much GABA, and we have nervous system depression. Too much glutamate, and we have nervous system excitation. We can throw some cations alongside that. So potassium being up is a bit like GABA. It causes hyperpolarization, and we can't fire. Sodium and ACH being up makes depolarization more likely in a lot of cases. So it's a constant seesaw of these. So if you take those pathophysiological hallmarks along with these as well, genetics, viral, metabolic, and structural, this accounts for about 2/3 of epilepsy. A third are still idiopathic. We don't know what the cause is. We just don't know. So how do we go about classifying epilepsy? Now, this is quite a thing. And the first question when we're thinking about a seizure is this a focal seizure or is this a general seizure? That's what we need to think about. Now, what's the difference? So here's the brain. A focal seizure is a focus, one specific location, okay? So for example, the temporal lobe. Now, if that's spread to the whole brain, that will be a generalized seizure. So think of the neurons firing a little bit too hard in the temporal lobe here, and then the forest fire spreads. So then a focal becomes a general. Doesn't always, but it can. Or you can just start with a general. So you have particular different regions of the brain. There's localization of the brain, if you think back to neuroanatomy, and this can account for quite a lot of different signs and symptoms. So temporal focal epilepsy, you'll have auras, so weird smells and taste, the sensation of déjà vu, and even changes to the emotions. You also have fidgeting and gesturing, the thing we call automatizations, will also occur. Frontal, now remember that, there's a lot of the prefrontal cortex here, but there's also the frontal eye fields, the premotor and the motor cortex. So you get brief, often bilateral, and often on waking motoric symptoms, the 3Bs, brief bilateral bed, because it comes on as you're becoming aroused, you wake up, and the firing kicks off. The parietal region, so if the frontal is motor, the parietal is somatosensory. So we have tingling sensations, a sinking sensation quite often, and sometimes some distortions as well to our own body. Bringing the Monty Python foot, the classic example is you'll feel your body sinking into the floor with a parietal focal epilepsy, a seizure, And now occipital, this is dealing with vision and associated symptoms, so they could have hallucinations, distortions, but nausea can also occur, as well as headaches, and then head turning. Things that are bothering your vision are going to make you feel sick. So, 3 different points to remember when describing a focal seizure. Which lobe is affected? So a temporal lobe seizure. Are they aware of the seizure? Yes or no? Are they spaced out? And is there motoric involvement? So you can remember that as LAM, L-A-M. So classic little example, patient's having a temporal focal seizure, unaware with motoric involvement. Classic description of a focal seizure. So let's push on to generalised seizures. If we've had a LAM for focal, we have a CAT for generalised. So the CAT is C-A-T, the mnemonic. So we have a clonic or a myoclonic seizure, an atonic or an absent seizure, and if we have an atonic, we have a tonic seizure. So now we'll just quickly define these words. I said there's quite a few words in classification. So, clonic and myoclonic. Clonic is jerking, okay? So the jerking can be rhythmic, so duh, 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 or it can be a sudden jerk, so dum, and then it needs a while to cool down, so it's like dum, 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 dum. So like one quick jerk of a joint, dum, and then it sort of like has a ricochet to slow down and down. This is the jerky, the moving that you see, the automatic, involuntary moving that you see in patients who are having a seizure. Atonic and absent seizure. So tone is the tone of the muscles. Atonic means no tone. So it's a drop attack, as we call it. You're listening to the phone, and then all of a sudden you have an atonic seizure. You lose tone, and you just flop to the floor, like jelly. Absent seizure is being spaced out, basically. And here's a little picture. So what about tonic seizures? So tonic seizures are the opposite of atonic seizures. So instead of being floppy, you're rigid as a board. So you also fall over, but you fall over because you can't bend to compensate. You just go straight like a statue and then fall sideways. Well, you can fall up or down as well. Tone is up. Okay, rigid as a board. So here is an example of a tonic seizure. And you look at those arms, and then there's a recovery, and then back into another one, like so. So clonic, myoclonic, jerking, atonic, no tones, they flop, absent, staring into space, and tonic seizures, where they're straight as a board. Now, generalised can have both clonic and tonic components. We call this a generalised tonic-clonic seizure. So you'll have intermittent phases of tonic, rigid as a board, and then clonic, jerking movements. Now, in the lecture, I show a video here, but I don't have copyright for it, so I'm not going to show the video for the recording, but you can just Google generalised tonic-clonic seizures and see it for yourself. I'm just going to skip ahead here. So, there's this thing called status epilepticus. Now, this is defined by NICE as a medical emergency. So this is a type of seizure, okay? It's a convulsive seizure that continues for a prolonged period of time. So it's very important that you are recording the time that the seizure started. Because if it's longer than 5 minutes, it's a medical emergency. Remember, the wildfire of electricity firing in your brain, out of control, longer than 5 minutes is a medical emergency. We need to intervene with some strong drugs. Or convulsive seizures that occur one after another with no recovery. The patient needs to fully recover. They can't be confused. They need to recover before another one can take place. The brain needs time to not have that wildfire. So if they're having repeated seizures without recovery, or one seizure is taking longer than 5 minutes, that is a significant problem, and that's what NICE defines as status epilepticus. So the anatomy of the seizure, we can break it down on time into 4 points. The prodrome, before the seizure occurs, early ictus, ictus, and post-ictus. And ictus is the seizure proper. So in the prodrome, a feeling or a mood change, plus or minus confusion before the attack. So they can think something might be coming on, but if they're confused, it might be something that is noticed in the collateral history that the partner notices. In the early ictus, you have an aura, if it's focally resigned, but if it's general, often no early ictus occurs. Ictus is the seizure proper, and I want you to pay close attention for double incontinence, bladder or bowel incontinence, tongue biting, so localized trauma and bleeding potentially, and then the post-ictal phase. So when the ictus is over, lie them on their side in the recovery position, head back, make sure that the patient has has their airway open rather. So in the post-ictus phase, this is an altered level of consciousness with memory impairment, and it can last a couple of hours. The differential, I'm not going to worry too much about this. MSN is the classic, usually particularly for the instance of med school questions. A seizure is a seizure, but it could be a migraine, particularly with auras. Sleep issues can result as well. Syncope, think about drop attacks like your atonic seizure. And non-epileptic attack disorder, this is a psychiatric condition. This is where the patient appears to be having a full-blown, for example, generalized tonic-clonic seizure or an absent seizure. If you hook them up to EEGs, electrodes on the head monitoring the wave patterns of electrical activity in the brain, it's normal. So these patients do not benefit from anti-epileptic medication. They benefit from antipsychotics, antidepressants, and going down the CBT and other approaches. Investigations are very straightforward. Basically, if you think of the differential for your syncope, ECG is going to be first line. You're going to do a full metabolic profile, full bloods, liver function test, and urea and electrolytes. And then B&M, that should be there, but take a glucose because the patient could be hypoglycemic. That's a key differential. And then these two, MRI and EEGs, are supportive mechanisms only, done in tertiary, very specific centres ordered by neurologists, if they want to rule out congenital abnormalities or if they really need something to support a particular diagnosis. That's really in the weeds for med school. Just be aware that that is a thing, but mostly these diagnoses are clinical, based on a very thorough history and examination and observing the seizure either in hospital or patients' families bringing recordings of it. MRI and EEG are not necessary, but they can support a diagnosis. And that's an important distinction. So for the management, I want you to think of 4 different groups of medications: benzos, barbs, sodium channel blockers, and calcium channel blockers. Now your benzos and barbs are going to do something to this little subunit here. Now this is the chloride channel, which is opened by GABA binding. Chloride is an anion, negatively charged, goes into the cell and makes depolarization of a neuron less likely. Loads of things bind to this. GABA will bind to it, propofol binds to it, loads of other things bind to it. But for our concern, barbiturates and benzos bind to it. Benzos to this GABA subunit and barbiturates to this beta subunit. So there's alpha, beta, and gamma subunits. When your barbiturates bind, there's quite a few examples, but one of them is pentobarbital, and your benzo lorazepam. There's a couple, midazolam, diazepam, don't worry about it. So, the calcium channel blockers and the sodium channel blockers, these block cations that cause excitation and depolarization of the cell to be more likely. Okay, your benzos and barbs potentiate GABA, so they're called positive allosteric modulators. So they open the pore of this GABA channel. So these open up, spread apart, and chloride can zip through to hyperpolarize the cell. Why do you want that? You want to make it less likely that these aberrant neuronal firings occur. They can't fire randomly. Your sodium and your calcium channel blockers are blocking excitation from occurring. So this is turning on GABA well, indirectly, it's turning on the GABA receptor, and this is turning off things. So you see there's a difference in mechanism there to come to the same effect for that seesaw, as we talked about before. Now, a few key ones you need to know about sodium channel blockers. There's valproate, lamotrigine, phenytoin, and carbamazepine. And the calcium channel blocker you need to know for Warwick is ethosuximide. Now, these 5, very effective, very well used, but what you need to be aware of is that they're teratogenic. So they're contraindicated in women of childbearing age who, the relative contraindications, but valproate in particular is particularly nasty as a teratogen. So you need to be particularly careful. So if we take these meds, we can plug them into different types of seizure that we've spoken about already. All of these are the first line therapies according to NICE. So for focal seizures, we're going to give carbamazepine and we're going to give lamotrigine. For generalized tonic-clonic, lamotrigine again, but valproate. For an absent seizure, valproate and ethosuximide. And for myoclonic, just valproate. So if in doubt, valproate or lamotrigine is your classic go-to first-line MCQ. So what about that emergency? So an acute seizure, status epilepticus, for example. Well, because it's an emergency, you do your ABCs, don't you? Of course you do. So your A is going to be airway protection, and do we need an adjunct? So if the GCS is less than 8, do we need to be talking to anaesthetics? Do we need to be doing something to protect that airway? Most certainly. B for breathing. High flow oxygen, 100%. Yes, definitely. C, cardiorespiratory check vitals and get cannula access nice and early. D, check the BM, glucose, 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 never forget glucose, and then do a proper GCS. The meds we're going to give, lorazepam is first line, and you can repeat lorazepam IV after 10 minutes if it's not working. Phenytoin is second line, that sodium channel blocker that we talked about. And then consider giving thiamine, which is vitamin B1, if the patient is likely to be thiamine deficient, so for example a chronic alcoholic, and that's your Pabrinex. Glucose might also be needed to be administered if the patient is query hypoglycemic. But that's if you're in a fancy hospital with ICU support, you can give these strong meds. If you're out in the community and you don't have access to ventilators and fancy anaesthetists and things, you might need to give buccal midazolam or rectal diazepam, which are the first line instead of IV lorazepam. And that is because we don't want to cause too much respiratory depression to stop a seizure, but end up causing respiratory arrest in the patient. So that is a quick nutshell summary, 3 words that mean the same thing, of epilepsy. Now at this point in the live lecture, I show a video. Now this is from Toronto Epilepsy YouTube channel about generalized tonic-clonic seizures. Again, don't have the copyrights. I'm not going to show it on a recording, but I strongly recommend that you go and watch it. It's called Tonic-Clonic Seizure. So type in tonic-clonic seizure Toronto Epilepsy into YouTube and you will find it. It's fantastic. All that remains for me to say is check out medguide.uk, our website. So that's 2,000 free questions and this recording is on here for Warwick Medical School students, but applicable to anyone interested in medicine. And please scan this QR code, 1-minute survey, so I get feedback from my portfolio, and all the effort I put into this and making sure it's correct is worth something and I can put it on my CV. Thank you very much for watching.